now back to Dr. Kurtzberg, and she will be speaking on improving Krabbe newborn screening patient experiences and outcomes. Thank you, Joanne.
Thank you all. And that was really so humbling to hear all three of you speak and hear your stories. So I feel like this is a tough act to follow. I am going to share my screen again. Just a second. Okay. So we just heard three very different stories, all very compelling, and they begin to touch on the challenges that families face, both with diagnosis of symptomatic children and also after diagnosis through newborn screening. And I really think there's so much work left to do, and we have a very long way to go. You know, there's newborn screening in 10 states, and with the RUSP application hopefully being successful this time, screening will likely increase over time. Most states are using cytosine for reflex or confirmatory testing, which means the babies with infantile Krabbe disease should be identified within a few days of a positive newborn screen. Some states continue to do molecular analysis of the GAL-C gene, and it's in different orders and in different timeframes from state to state. But at the end of the day, we will have populations of babies, small but real, who have infantile Krabbe disease and babies at risk for later onset Krabbe disease. And you've heard it alluded to, but at the later onset category, there are babies with late infantile disease, and then juvenile and potentially adult onset disease. So this is just a chart to talk about the key points of management of screen positive babies. So you have a newborn screening result in the infantile Krabbe disease population. You have low enzyme and high cytosine, and referral to a treatment center is emergent and urgent. Molecular testing should be done, but not delaying referral. It can be done after referral, and it should not delay treatment. And again, that treatment is urgent and emergent. And of course, related to the treatment, there will be follow-up that is lifelong. For babies at high risk for late onset Krabbe disease who have low enzyme and intermediate cytosine, they won't be referred to a treatment center right at birth, and it is not an urgent, emergent situation, but it is a situation that needs attention, and it is a situation where molecular testing needs to be done to help further define the risk category. Treatment may occur later in infancy or childhood, depending on the form and the onset. And studies will be required to monitor disease activity so that treatment can be initiated at the earliest onset of disease, not after significant symptoms develop. And for the lower risk category of at risk for later onset Krabbe disease, which might be with a normal or an intermediate cytosine, again, there wouldn't be referral to an immediate treatment center. There would be molecular testing. There would not be treatment in childhood. And follow-up would be clinical without invasive monitoring or imaging or other types of testing. But there should be a very heightened awareness to the early symptoms of Krabbe disease so that workup can be done if symptoms develop. So there are many challenges, and you've heard some of them in the last three talks, but to this whole process. And I'm listing some of them here. First off, the testing procedures and algorithms are not standardized, and I mean newborn screening testing procedures and algorithms are not standardized between the various state newborn screening labs. Newborn screening is federally mandated but state funded, and states decide what they will add to their newborn screening panel and how the testing is done. Reflex cytosine testing is done by most labs, but it's not done the same way. And sometimes it's a send out, sometimes it's done in-house. And the timeliness of the results is different from lab to lab. Some states also perform molecular testing, but that again is the exception, not the rule, and varies from state to state. And timing for return of these test results, what is confirmed before transmitted to a family, and all the algorithms involved in communication are not standardized between states. Newborn screening labs may communicate results to different physicians down the road. It may be the pediatrician of the baby, might be a geneticist, it might be a neurologist. There are different algorithms in different states, and again, they are not standardized. And then informational materials are often limited, only distributed by some states. Many states have rules about not distributing information like brochures or referrals to foundations or other sources of information. So it limits what can be done in an easy distributive way. And then there are real HIPAA regulations that can prevent referrals directly from the newborn screening lab to a particular expert in Krabbe disease, whether that expert is in state or out of state. And then interpretation of results, as you heard from Deer's talk this morning or a few hours ago, may not be straightforward. It may not be clear that, particularly in the risk for later onset disease cases, whether this is Krabbe or not. Consultation may be important, and as new mutations are identified, it's going to become even more complex and in some cases confusing. You've heard, and I'll reiterate because I've heard, and many of us have, that parents often hear initial results from an individual who's not really familiar with Krabbe disease. And sometimes, probably frequently, they hear information from someone they don't know, someone who's cold calling them, giving them bad news on the phone, which in itself is a very difficult experience. Treatment options are limited, it's complicated, and they're varied, and there aren't necessarily recommendations that are consistent between experts. Some investigators have biases around one kind of treatment or another, and that I think makes it harder for families to navigate the pathway for referrals. You also have to deal with insurers, and private and public insurance companies prefer to have babies treated in state or in network, and can often complicate the process of referral to other centers, particularly if they're out of state. And there's really discussion about whether a referral to a quote unquote center of excellence is a critical step in the process. And again, some babies with the risk of later onset Krabbe disease are definitely not straightforward, and their risk of actually developing Krabbe disease isn't known. And we are still learning about this, both through the Newborn Screening Council and through other methods that labs are sharing information. Learning of a diagnosis of infantile Krabbe disease is a shock and extremely traumatic, as you've heard. It's both difficult to communicate the information for the provider and difficult information to hear for the parents. Parents need to learn a lot very quickly. They may be receiving information from people they don't know or trust. And then they're asked to make quick decisions if the baby is going to be referred for transplant or soon gene therapy. So there's not a lot of time to think it over, get information, do research, or consult many experts. And regardless of who the provider is, there are gaps in communication, which are inherent to the process and need to be corrected. Referrals may be necessary, and out-of-state referrals are harder to get. And again, sometimes the providers involved don't agree on what the next steps should be. The same is true of late onset or risk of late onset Krabbe disease. And while there's time to do additional testing and there is no need to rush to treatment, it can be very hard, I think, for parents to not have direct answers and not know right away what's going to happen and what the path forward is and what they can do about it. A lot of the test results are hard to interpret. With newer mutations being identified, it's getting harder, not easier. And frankly, a lot of the quote unquote experts in the area are not always sure it is Krabbe or what to do about it. And I think that makes it a lot harder for families to hear that information and deal with that information. Sometimes a definitive diagnosis and timeline for development of disease just isn't known. And that's hard. It's hard to know you're at risk, but it may happen, it may not happen. You didn't have any choice about learning about whether you were at risk. It just happened, and here you are. And I think it's difficult for the clinicians to communicate all of this, particularly about predictions of the likelihood of whether or not a particular child will develop Krabbe disease. So what are the potential solutions? And I will say we have been working on this in the Newborn Screening Council, and also many groups interested in Krabbe disease, interested in newborn screening in general, interested in transmitting difficult, sometimes bad news to families who are unsuspecting, are all continuously working on this and discussing this. We've heard that some parents may benefit from interacting with a knowledgeable individual to help them navigate the pathway forward for their baby. This is hard because how do you make that referral, and who does that referral go to? And what are the liabilities of the individual taking on that task? And what kind of knowledge do they need to have? And what kind of backup do they need to have to navigate the interpretation of some of these unclear results? I do believe newborn screening labs need to determine ways to direct families and providers to accurate and balanced information and to people who can help them. And we've all talked about websites. Google was already mentioned. There are ways to get your search to come, your item to come to the top of a Google search, but traditionally Google charges a fair amount of money for that. And we're trying to find out, Anna, is whether they would do something as a public service, since this is a rare disease diagnosed through newborn screening. Developing information sheets that have more information than the ACMG sheets, I think would be very helpful. But then figuring out a way that newborn screening labs can legally distribute it is again a challenge. We are planning webinars for providers who receive information from newborn screening labs and then have to transmit information to families. And we believe the Newborn Screening Council can serve as a consultative group that helps interpret these confusing, sometimes test results, particularly in the cases of the risk of later onset Krabbe disease. So there's a lot to learn. We have a long way to go. I think it's incredibly challenging, and I think everyone who's in the room recognizes that, but we're still struggling with the best way and the best paths to move forward. So I will stop there and entertain any questions.
Thanks, Joanne.